And this is Bridget. Go ahead, Bridget. Today we are going to talk about nursing management of subarachnoid. But to begin the session, we're going to show you a short video because I like it, and it's completely stolen from the internet, so it's proprietary, but it's still good for you guys to watch. Well, I'm pretty sure everything we do is. It's really well done, though. I like it. Was there sound? I forgot to check.
Pumps blood to your brain through blood vessels in your neck. These blood vessels, called arteries, branch into even smaller arteries that bring blood to your brain cells. Some of these small arteries join each other to form a loop known as the circle of Willis. The walls of the arteries contain special muscle and elastic layers that help them adapt to the blood pulsing through them. Sometimes diseases, injuries, or birth defects can cause a weak spot in the wall of the arteries in the circle of Willis. These weak spots usually form where arteries branch. Over time, the pressure of blood flowing through the artery stresses the weak spot further. The constant blood pressure can cause the weak spot to balloon out and form a bulge called a cerebral aneurysm. This cerebral aneurysm is the most common type, called a saccular or berry aneurysm. Over time, the aneurysm may grow and push on nearby brain tissue or nerves. Blood may also leak from the aneurysm. If its wall gets too thin, the aneurysm can burst or rupture and spill high-pressure blood into the space around your brain.
All right, and that was basically that's basically where we're going to start. So I love that because it starts our presentation just perfectly. Let's see. So this is how we started. Go ahead, Bridget.
Okay, so
So we like the video because it's a good introduction of what it looks like, and I think it was a good example of what happens when an aneurysm ruptures. However, as you can see, it said sample use only. We couldn't even put it in a presentation. So here's our disclosures, just for general knowledge, that we stole a lot of things. That it's definitely proprietary. If this was going to be a public venue, we wouldn't be able to share it, but it's with NSICU only. We talked with MCCS, and there's also some other new guidelines. I think it was a 62-page document that just came out, right?
the AANN just came out with updated guidelines for nursing care of subarachnoid hemorrhage. Not too much has changed, but we did refresh it, trying to make sure we were up to date.
And so just so you guys know, this entire presentation is meant to be interactive, and there's a few things that are like facts, but our whole goal is to get you involved. This is not about us just talking to you.
Yeah, I even have treats, so if you participate, I went and found good stuff like fireballs, lemon heads from your childhood, cow tails, all the good things.
What's a cow tail? I don't even know what that is.
What's a cow tail?
Yeah. So let's talk about, subarachnoid hemorrhages, they're only about 5% of the strokes out there. Unfortunately, as you guys know, we see it so frequently on our unit that in a way, I think we're skewed. We forget that it's actually quite a rare type of stroke. A third of the sufferers die before they even come to the hospital. Dr. Zakaria did a talk on subarachnoids maybe a year ago, and she said, well, a third don't make it to the hospital, a third never leave the hospital, and a third never work again. So it's a very devastating injury. For those that arrive, the mortality rate is about 45% for the first month, and then and 50% are typically left with some major neurological deficits. Sometimes it's from the initial hemorrhage itself. Sometimes it's from hydrocephalus, damage to untreated hydrocephalus, and then also the most important thing that we wanted to talk about today was delayed cerebral ischemia from vasospasm. And you might have heard some of MCCS, they write it in their notes, DCI. DCI is delayed cerebral ischemia, delayed cerebral infarct. We're going to try to get us used to using that word DCI. So our goals for today's talk is to understand how nursing vigilance in particular can preserve brain function. So 50% of our patients that come in with subarachnoids are going to have major neurological deficits. If we're vigilant, we may be able to prevent that. And so that's why we are felt very driven to have a good talk about this. Some of the doctors in MCCS have talked before in Neuroeducation Day about subarachnoids. You've all had it in your orientation. However, I think they're talking from a different perspective. So our goal is to talk about it from what we can do. How to prepare for subarachnoid admission, to understand the different phases of care, and talk about hydrocephalus, and again, the better understanding of DCI prevention. So, go ahead, Bridget.
All right. So, your patient has subarachnoid hemorrhage. What are we going to think about? So, we're really lucky where we work because we usually have an image before a patient comes up. They usually, sometimes you do get a surprise admission. However, most of the time they go to the ED, they get a head CT to rule out if they're what type of stroke they are, if they need TPA or they don't need TPA. So a lot of times you have a CAT scan ready to go, and you have some other information that you can use to set up your day before you even meet your patient. Your patient is still in the emergency department. So what we can do is utilize the information from when the patient's in the ED to help set up the day. Again, this is like a very nursing-driven presentation. I'm not gonna teach you anything that MCCS could teach you because I'm not MCCS. So I really want to focus on just making sure everyone enjoys. If you have a great day and you do strong work and you feel organized and focused, you leave your 12-hour shift really liking your job instead of why did I become a nurse? So a lot of this is driven to maybe help get you better organized in how to have a successful day and then give successful care. So we can use the Fisher grade and Hunt and Hess score, which we're going to talk about a lot, and you have it on the front page of your handout. And then the cause, we'll go over that in a second. The patient's current GCS and the patient's current blood pressure. So we normally have some of this information, if not all of it, before the patient comes up. So I want to try to get everyone to get used to thinking about things in this order as we go through. We're going to have some patient setups and some scenarios. We're going to try and drive it in this order of what to think about with what we're going to do. So how many people look for this FGHH? That's how it's normally written in MCCS's note before you get a patient. How many people? Okay. So not many, but it's a great tool, and we're going to talk about it so you can figure out how busy you're going to be. The cause, what are some causes? We just watched a video, but what are some other causes of having your patient could have had a subarachnoid hemorrhage? Anyone? I'm going to make you work for it. This is not a silent presentation.
Uncontrollable high blood pressure.
Yay! Okay, anyone else? What's another reason your patient could have a subarachnoid hemorrhage? Drugs. Who said that? That's true. There you go. Trauma. That's true. We don't see them, but it's true. Oh, sorry. I kind of chucked that at your head. Anyone else? That could be it. Dangerous in here. Okay. However, causes are good because MCCS will address them a lot of times during their notes. So their notes are all mostly the same. So in that right-hand column, they're going to have the causes, and that can help direct you to maybe how much management you might need to be doing in a certain area. Is their blood pressure going to be high? Is their blood pressure going to be low? Mental preparedness. Patient's current GCS. This is also really important because sometimes the patient that we meet is not the patient MCCS met when they went to the emergency department. So that's going to be in one of our scenarios coming up, but you could call and be like, this is my exam. They're going to be like, no, I saw them. It was blah, 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 blah. And, well, that's great. And I'm sure it was. But that was 25, maybe even an hour ago. A lot can change in an hour where we work. That's why we do hourly neuro exams. So sometimes it's good for your own frame of reference to know what the patient was doing while they were in the emergency department. Have they gotten worse or have they gotten better by the time you meet them? It's just good to keep in mind, and it can set yourself up. Even if you go down to the ED and you're like, I read you were alert and oriented ×4 and your left side was weak. And then you meet them and they're alert and oriented ×2 and their left side's flaccid. So you can start the alarm from the emergency department instead of starting it from getting back up to the unit.
I think also for me, if I were to get an admission and I were to see this image, for example, I would know that I'm in for a lot of work. So I would prepare myself mentally to have everything ready with my other patient prior to, because I know I'm going to be stuck in a room doing a lot of things.
And we're
So,
going to hit that home too.
yeah.
That's one of
Okay.
our goals. So, one more thing.
Well, I'm sorry.
Does anyone know if this is your scan, regardless of all this, what do you think your blood pressure goal should be? 90 to 140? I'm deaf in one ear. You guys got to help me out. What did you say, Lacey? Less than 140 is perfect. Did anyone else say that? It's going to be okay. That's perfect, 90 to 140. Again, you can start knowing how you need to take care of your patient before you meet them. If you're creeping on the ED charting, which we all do, and you see that their blood pressure is 220 and they haven't started a cardine drip, you're going to want to get that started because we want to take care of our patient. We don't want them to have PCI. So you can just mentally get ready for how your patient's going to be, what they're going to look like, and what you're going to have to do.
Okay. So this is basically, go ahead. Yeah.
Okay. So this has been one of my best friends since I first met Dr. Altwheel like 8 years ago. So Dr. Altwheel taught me a long, long, long time ago to commit this to memory and that it would help make me a better nurse. And we were both much more spastic 8 years ago, but he was right, per usual, and it really did help me. And I use this every day, all day when I'm at work. So if your patient's graded a 1 and a 1, if you're not familiar with this, I don't know how much everyone wants me to go over it, but like you can use this to set up your day. So if you have one patient in 10 who is intubated, they're on a CPAP trial, and you're getting a subarachnoid hemorrhage, and they're a 1 and a 1, you can kind of, before you meet them, expect how much work they're going to be. This person should be able to walk, they should be able to talk, they might walk and talk, they might want to do a lot of walking and talking. So you can mentally prepare for that. If this person's a 3 and a 3, a Hunt and Hess of 3, that person's already going to be confused, they're already going to be a little lethargic, and they're already going to have some sort of deficit. They're going to have more than a millimeter of blood vertically through their head on the CT scan, which is substantial. The difference between 3 and 4 is also substantial. 2 is less than a millimeter of blood, 3 is more than a millimeter of blood, and a 4 is comfort care. So it's a joke, but this can help you set up how much work you're going to have to do. So you have someone coming in that's a 2 to a 3, that's more work than someone that's coming in a 4 to a 5. So someone that's a 4 to a 5 on the Hunt Hess score is going to be very sick, is going to need things. I'm not saying they're not a lot of work. They're just mentally, you already know how much can we help this person. Are we stabilizing them till family can come? Are we just doing what needs to be done? Does the family want everything? One of those types of situations. So people that come in that are a 2 and a 3 have the highest risk for DCI, and their exams are really hard because they're already lethargic and they're already confused, and those are the hardest to follow. So that's going to be more time consuming on your day. So we're going to talk about this more, so I'm just going to let that be right now. And then
Yeah, the only thing I want to point out is remember that the Hunt Hess is a clinical representation, how the patient looks, and then the Fisher grade is based on the image. So how much blood you see in the radiological image. So here's one of our first scenarios. Yay, look at that. Patient has the worst headache of his life, and you might have seen the acronym WHOL during coitus. We thought this was a very great example because this happens a lot. The patient arrives in the AD, has headache, light sensitivity, CAT scan shows a subarachnoid, and they're graded Hunt Hess grade 2, Fisher grade 2. So you can look at your sheet right now and get an idea what that means. And then we want you to start thinking about.
we did the pauses, we won't do them every time, but it's good to just train your brain to think about why did this happen?
And the GCS is 15, blood pressure's 182 over 79. What do you think the goal should be? One more time, what should the goal be, everyone?
What should the blood pressure goal be? Less than 140. No, that's wonderful because, you know, some sometimes the goals and everything, the orders aren't done by the time you get to your patient, and instead of having to stop or send someone out or not know what you can start doing, this is universal. You can start operating under treating, making sure your patient's blood pressure is less than 140 without an NSICU goals order going in saying what's my goal. And then when MCCS comes in, you can be like, I've been keeping them less than 140. What do you want to do with the patient? Because we do nuancey things depending on exactly what the patient has, and the better images we get, and the better exam we get, and what they're going to want to do. But they're also always tweaking from less than 140. So if we aim for less than 140, and then as soon as they get to the bedside, if they want to direct that wherever they want to direct it, just letting them be, 180, 190, 200, or too low, that's also.
So with this particular patient scenario, what do you guys think? Let's talk about, you found this is your patient, you went to pick him up in the ED. What would be like some of the first things you'd be thinking about?
For your patient, what do you think they're going to need?
Yeah, what do you think we're going to do first?
Or how do you think they're going to look? Anything. So their Hunt has 2 Fisher grade 2. We're not trying to trick anyone. That's why we gave a sheet. They're going to need pain meds. They're going to have a headache. Everyone that's a Fisher grade, a Hunt has grade 2, is going to have a headache. They all have headaches. So that's very true. What else do you think they're going to need? Most likely pressure control. Awesome. What else do you think they're going to need?
Possibly.
Possibly. There are really no wrong answers. IR. They could need IR. Absolutely. So plan for at least one road trip. If you have anything that starts with Hunt has 2 to 4, you should plan to go on a road trip with your day. So again, if your other patient's on a CPAP trial on the wake and could extubate and they're in 10 or 15, and you might already go to IR, you probably might need a head CT. They're going to need management. Just those things alone are very time consuming right when you get someone. So you might want to reach out to the charge nurse or your buddy. Hey, I have a person in 10 that's on a CPAP trial and they might pull out their tube and I think I'm going to get sucked into my other room and it's an 8. Like I'm never going to hear them. Like just set yourself and your day up for success. And I feel like the more we do that from the beginning of getting our patient, one, it's also better for your buddy. Like if I'm like married, I'm getting a patient, I'm expecting blah, 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 blah. My person calls every 20 minutes and wants to be walked to the bathroom. Like, can you help me out? Instead of being in the room, the person already wants to go to the bathroom, no one's available to take them, then you feel like you have to leave. Like Mary already has my back. And we do such good teamwork on our unit already that I feel like if we just bring it up a little earlier, that it will be even better. Because we do amazing teamwork where we work. So we can even make it more awesome.
Okay, so this is just kind of general information. We brought up the multiple causes of subarachnoids, but in our ICU, it's typically a ruptured aneurysm. Sometimes it is an AVM and AV fistula. It could sometimes be drugs. There's been mycotic aneurysms. There's been a lot of other types of ones. But this is basically kind of the idea. The point of this entire slide was just to show you this beautiful picture, which I love. If you see, this is the artery in the subarachnoid space with the aneurysm. And so this exactly explains to you, if the blood bursts here, it's going to be right there in that space. And sometimes it will migrate into the parenchymal tissue, into the tissue itself, and then that becomes a Fisher grade 3. So, and again, that's the radiological image. So people that are Fisher grade 3 are the highest risk for DCI related to vasospasm, which is, again, something we're going to talk about when we get to that. But again, most important thing to remember, blood pressure management is critical. So here's another scenario. Isn't it exciting? Come on, everyone. We were so proud of our little scenario. So, okay.
It's all good.
So a patient was playing on the floor with her children, and I actually remember a patient that actually had this exact story. And all of a sudden has the worst headache of her life, falls unconscious immediately. They call EMS, they intubate right away. They're posturing. The pupils are still 3 and brisk, which is nice. Stat head CT shows it's a large subarach. Blood pressure is pretty high. The patient needs to come into the NSICU immediately. This is when you have your charge nurse or you have Dr. Ramesh saying, go down there to the ED and go get this patient right now because they're screwing it up. I know that's happened many times. So let's talk about what can you anticipate is going to happen for this patient. So we had the one patient with the headache, and now here's the other scenario. I can't remember what's the next slide, so go ahead.
Anyone? Come on.
What do you think is going to happen with this patient?
We're trying to drive home a lot of the same thoughts. So what What do you think you're going to have to do for this person?
IR, EVD.
Cardine drip. Perfect. CTA.
Well, we intubated already.
Intubated, but yeah. Call respiratory.
What else can you see happening possibly?
How busy do you predict you're going to be for the like first 4
Gonna line the
hours
patient.
of your shift? Like sweating, busy. Like my hair would be up.
The first thing that comes to me,
Okay?
this patient's posturing. So what do you think is one of the big interventions that we're going to be doing?
Yay.
Uh-huh.
Brain code box. Get the brain code narrator.
There's one more that I'm thinking of. I'm hoping someone's got it.
Central line and EVD.
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 And we're going to get into that. Okay, so here we go. So the first, we call this phase 1. So we're trying to, there's basically three phases of care for anyone who has a subarachnoid. We have the before intervention, so before they have coiling, so the first 24 hours typically. Then like the first 2 to 4 days. And then phase 3 is the vasospasm window. So here's phase 1, the first 24 hours. So we talked about this. What's our blood pressure goal, everyone? Thank you, everyone. And why? We already talked about it. Okay. So the other thing that's important is to correct any anticoagulation. This is a patient, has a ruptured aneurysm, has AFib, and is on Coumadin. So what's really important? This is for anybody who has a bleed and is we need to reverse it. We sometimes forget that because we get caught up in all the other orders, but anybody who's actively bleeding needs to have their INR or their PTT corrected immediately. So correcting anticoagulation is very important, especially if we have any knowledge in their history that they're on any kind of warfarin, but that's true for any bleeds.
Yeah, and this can be nursing driven. If it wasn't already established and the lab wasn't already sent, and you find out that they were on any type of anticoagulation, we need to get the labs off. Like, we need to know what it was. We need to let them know. We need to see if we need to reverse it. We need to see where their labs sit. Like, this is an emergency for us because we're the ones drawing the labs. We're the one giving the drugs or getting the, the blood products. So, yes, it needs to be ordered. And yes, a lot of times it does come from MCCS. This presentation isn't to take anything away from what they do or what we do. It's that we all need to do it together. And there are some things that really fall on our shoulders because we're actually the ones giving the products.
Right.
And we kind of judge how fast that happens.
Yeah, and the whole point of that is that we can drive it. And sometimes you'll even get a patient transferred from another hospital where they should have corrected it before they got transferred. And so then that even becomes, that's even more of a clock. The next thing is the EVD, typically, placement for hydrocephalus, which we're going to talk about. And then preparing to go to IR or coiling, which everyone said all the right answers. Yay. And so here's my pretty picture that I love. Bridget laughs at me because I added a lot of pictures. I love this picture because it really shows the example of basically 4 different approaches for treating an aneurysm. Here's the coiling itself. This is coiling in a stent. This is just a stent. And then this is OR going for clipping. So, okay. So we were talking about patient B. So the CTA revealed that the likely source of the subarachnoid was a ruptured right MCA. That he'll need to go to the OR for clipping. He's not a candidate for IR. Or she. I can't remember if I made it he or she. So we put an EVD right in. We got a subclavian put in. We give 23%. The aneurysm is then clipped in the OR. The patient returns after right hemicranie. And now.
Okay. So going with that patient, all that just happened to patient B. They just came back from the OR. What is the first thing you should do? The first, there's not one thing, but what are the first 1, 2, 3 things that are the priority? Neuroexam. What else? Yes. What else? You can do that. That's fine. I'm looking for something else too.
It's not a trick question. I swear it isn't.
No trick question. That's if the level's still there. Yes. Oh. Blood pressure. Blood pressure, blood pressure, blood pressure. So a lot of times when our patients are in someone else's care and they're traveling back, anesthesia and other people have their own way of doing things and operating and giving meds and setting up. And when those people travel, sometimes when they get back to the bedside, you'll notice anesthesia's collecting their items. So everything might have been fine, but a lot of times they're pushing drugs, through syringes. So sometimes there is a grace period of where there is not coverage for a patient, and they get back to the bed and we're moving them over and everyone's schlepping in the room and cleaning people and doing all this stuff, and then you do your neuro exam. One thing I've noticed on our unit, which is good, it's like a catch-22 thing. I've been calling it like the pit crew service of the neuroscience ICU. We are so good when we get an admission, like 5 people come to the room, your patient looks pristine, every arm is elevated on a nice white pillow, your SCDs are on, your MRSA swab's done, but sometimes they're not hooked up to the monitor while we're doing this pit crew thing. So it's just a friendly reminder that someone's job in the pit crew needs to be putting the patient on the monitor immediately, getting a blood pressure immediately, checking the EVD before they look pristine. We kind of fell into this thing where we're so good at making someone, the room gorgeous, the patient smells great, everything looks so good, but we still don't have a vital sign. So there's not a large gap there. I'm not saying that it's like, oh, I'll get a blood pressure eventually. That's not happening, but it should be done before the patient looks beautiful. So just in case we're missing something. So I'm going to do better at reminding, and also while I'm in the room, of making sure that we're doing those things. The bedside nurse should be getting the neuro exam, obviously. So whoever's patient that is coming back, they know them the best. They should be getting the neuro exam. Someone else should be on top of getting those leads on and getting the blood pressure ready to go.
And I think sometimes these things can conflict. So sometimes your patient comes up and they're on propofol and they have a beautiful blood pressure, right? And then you want to get your neuro exam. You have to turn off the propofol and all of a sudden their blood pressure is 220, right? So anticipatory, we can have some Labetal already. So we can do an exam, but try not to, blow their brain up.
Make sure that they're ready for an exam. This is also a hard spot. It's like 50-50. Some patients come back. I've been here a long time and I'm still not able to predict when they're like, do not wake them up, or why don't you have a neuro exam yet? I don't know which way who's going to fall and what doctor's on or how the patient is and how their mind works and what they're going to want. So before you wake someone up, it's better to keep them in the good zone with their blood pressure and asleep, and double check, when do you want the first neuro exam? Do you want me to hold it now? I'm happy to. And like Maya's saying, just know you might need to have PRNs already on you, ready to go. Or they might say, no. We don't want a neuro exam until tonight or in an hour or whatever. So just check first. It's best to make sure your blood pressure is within goal. What else can happen with your blood pressure if your patient comes back from a procedure?
It can be too low.
It could be too low. And what might happen to your goal? It changes. So if you don't know what they're going to change it to, you can stay under 140 until you contact someone from MCCS. It's not wrong. We definitely want to watch out for fluctuations, which we're going to get to. But, if your person gets clipped or coiled, everything went great, they're expecting to wake the patient up and extubate them, but you don't know that part yet, your goal is probably going to be liberalized. But until you're face-to-face with someone, MCCS, or you have really good communication over the phone, don't do that yet. Make sure you wait and that they give you that information.
So we had talked about it a little bit, but they're going to take a little slide right here and talk about hydrocephalus. I love this slide because it shows the dilation of the ventricles. So remember that your brain is bathed in cerebrospinal fluid. It's here and it's all the way around. So when you have hydrocephalus means water on the brain. How many of you have seen my bathtub analogy?
We're going to see it again today. Get ready, folks.
Excited. All right. So when I explain to patients' families what an EVD is and why we do it, I always use the bathtub. And I often draw a clawfoot tub, but in this I couldn't do it. So pretend like it has claw feet. So to understand hydrocephalus, you need to understand kind of quickly what the brain flow is, the cerebrospinal fluid flow in the brain. So the choroid plexus, which are they make the cerebrospinal fluid in the ventricles. In the lateral, third, and fourth. And the only key takeaway is it makes about 20 mLs an hour. And then you have a certain amount in your bathtub, right, filled up, and that's that's the body of what's in the ventricles and all the way around the brain, all the way down the spinal column. So it flows, it gets going here, it goes into the third ventricle, the fourth ventricle. It's not that important. Point is there's a certain amount of volume, right? And then you absorb about 20 mLs an hour and in the arachnoid villi. So the bottom line is this is steady state. You're making much, you have making 20, you have a certain level, and then 20 comes out, right? So what happens to subarachnoid patients? Why do they develop obstructive hydrocephalus? Does anybody know why?
Swelling.
Sometimes they'll have blood in the ventricles.
Correct.
Correct. Perfect.
The large protein hemoglobin. So look how big hemoglobin is. It is this large. It's a really large protein. Cerebrospinal fluid actually has very little protein, and so it goes quickly through. So remember, the villi are like kind of like the think of like your intestines, how you absorb on a microscopic level. It's the same idea. It's really narrow. Poor little Emily's falling asleep. But anyway, so the blood gets in the way, so you're not able to absorb. And so here's I like this picture too because it shows, see how the artery is in this blue thing is the space, and the artery is in this space. And here all around the wall is where it's being absorbed, the cerebrospinal fluid. So what are we watching for somebody that has obstructive hydrocephalus? What are we looking at? When does it become an issue, a concern? Huh? What is a symptom of hydrocephalus? Correct. The number one thing is level of consciousness. Excellent. Who just said it? Who said it? Yeah, so the number one thing is drowsiness, level of consciousness. And the thing that I want to, kind of a takeaway too, is especially if you have a young person, they compensate. But when they decompensate, it's like this. In a half hour, you're going to have a patient who's talking to you to being like emergency. So level of consciousness. So we're talking about, hey, open your eyes. And they open your eyes to sternal rub to finally get them to open their eyes. That's the type of difference in level of consciousness. But that is the number one, decreased level of conscious extreme drowsiness. That is the number one sign of hydrocephalus. So often.
You usually have a GCS change of 2.
Perfect. Yes.
So
yeah.
like if you're 12 and you go to a 10, that could be a sign of hydrocephalus. There is usually when it finally builds up and you're overflowing, you have lost usually 2 points on your GCS scale. So it should be a trigger for us to make a phone call to MCCS right away.
What is the treatment? EBD, yay everyone! Yay!
I can't eat so many of these.
Now for chronic hydrocephalus is different. We're talking about an acute. So okay, so again, so obstructive. So we're going to go back to my analogy of the bathtub. So this is not poop; it's blood. Everyone, this poop. I'm like, I know. Come on, guys. I only have so much artistic thing that I could do. So we talked about the blood is now hindering the absorption. So when I explain it to families, I'm like, it's like a big hair clot in your bathtub, right? And then, so, or poop, whatever. So your body's still making the cerebrospinal fluid. It has no idea that there's something in the way. And then so what happens? The amount of cerebrospinal fluid, the level of your bathtub increases, the pressure increases, but you have a cranium. It's a closed space. So it's going to start increasing pressure. And in addition, you have the original insult of the injury. That's also going to cause edema. So imagine it's a couple. It's a double prong type of thing. Oh, wait, I hit the wrong way. Sorry, guys. So the EVD is kind of like the overflow, the drain that you have on your bathtub. I'm sure all of you, or your sink. I know someone didn't know that there was an overflow in the bathtub because they never took a bath. So I was like, okay. Or your sink, remember? So that's the whole point of the EVD. We don't want to lower the level. We want to have cerebrospinal fluid in the brain. It has an important role. But we just want to offset the fact that your clot is in the way. Okay? And so this is a great example of a hydrocephalus of a subarachnoid. Here's the starfish pattern, which if I see the starfish, I know I'm in for a lot of work. And then here is the hydrocephalus. You're not really supposed to be seeing some of these. These are not, you're not supposed to, is this the fourth one? Or is this, you're not supposed to usually typically see this any more than as a slit. So if you start to see it, they have a hydrocephalus. So we have our great patient scenario.
Okay, so this one we're going to ask a lot of questions about. So he's actually in your handout, just so you can follow along through the slides.
So he was found on the bathroom floor by his wife. He was lying in vomit. He was lethargic and confused. He had a terrible headache. They brought him in. The CT shows that he has diffuse subarachnoid, Hunt-Hess grade 3, Fisher grade 3. He's kind of oriented. He's weak on the left side. On the right side, he's localizing. Though he's kind of sort of following commands on the right side as well. Okay? So possible causes, again, we talked about this. His GCS is now 10. His blood pressure is 154/62. What do you think the blood pressure goal should be, everyone? One more time. Thank you. So let's talk about planning your day.
Okay, so your other patient is post-TPA and they're a talker, and it's 2 o'clock and they have an MRI planned for 4, and this is your admission. So hopefully you've already set up your room for an admission, but if you haven't, what do you think you'll have to make sure is in there? What do you think this patient's gonna need? Look at, you can refer to your other sheet again. Airway. Airway is huge if someone's a 3 and a 3. So they're either most likely already intubated or they are going to probably be intubated within the first 12 hours of their arrival to the unit. So make sure you have 3 suction canisters. Make sure you have an ambu bag. A lot of times now, because we're like really getting rid of everything in the room and starting afresh, sometimes the unused ambu bags used to kind of stay perched up in one of the booms, and they're being either wiped down, or if the patient was whatever, everything's being thrown out and we're starting fresh. And I feel like sometimes we're missing to put the ambu bags in the room with, like, we get the bucket, we get the wipes, we get all the stuff, but since I think we're kind of used to the ambu bags unused being around, we're forgetting to put a new one in. So it's just mindful, especially if you're getting, I mean, you should have one anyways, because heaven only knows what could ever happen to a patient at any given time. But if you see this coming, make sure your room's set up to intubate, because it's very possible that you might intubate. What else might this patient need?